Welcome, everyone. Welcome, and thank you for joining us for another informative Newborn Toolkit webinar. Today's webinar is on babies and bugs in hospitals, time to act on infections and AMR. Welcome, please introduce yourself in the chat. Bienvenue, s'il vous plaît. Please introduce yourself in the chat. So today's webinar is to mark World Sepsis Day, and what is the Newborn Toolkit? So the Newborn Toolkit is a multilingual, multi-country learning platform for high-quality small and sick newborn care. We had over 55,000 unique users in 2024 from 170 countries, and we aim to be a one-stop shop for newborn care resources tailored to high-burden contexts. We have 1,000 tools in 15 languages, technical content in French, and linked communities of practice in French and English. This webinar is being translated to French, and we hope that our French speakers will be able to input and learn today. So today's topic is on babies and bugs in hospitals, time to act on infections and AMR. On the screen now, you see our QR codes for the Toolkit newsletter in French, and our social media platforms on Blue Sky, Twitter, LinkedIn, and Facebook. Please do join us. Please do input, and let's learn faster together for newborn care. So we have good, exciting webinars lined up for 2025 still. In October, we'll have a webinar on financing in newborn care. So financing futures, scaling up newborn health in a changing funding landscape. And on 18th November, we'll have a webinar linked to World Prematurity Day and also we'll be celebrating the Toolkit birthday. My name is Mbozo Sipalo. I'm the co-lead of the Newborn Toolkit, and happy now to hand over to my colleague, Lauren, who will talk about the webinars lined up for our French speakers. Over to you, Lauren.
Merci. Donc, bonjour et bienvenue à tous nos participants parlant français. Si vous voulez écouter le webinaire en français, s'il vous plaît, cliquez le bouton de traduction affiché sur la barre de menu de Zoom. On a aussi quelques webinaires à venir. Le 21 octobre, on a un webinaire sur financer l'avenir, améliorer la santé des nouveau-nés dans un contexte de financement en mutation. Et le 18 novembre, un webinaire la Journée mondiale de la prématurité et anniversaire de la boîte à outils pour les nouveau-nés. Donc, bonjour et bienvenue. Veuillez introduire dans le chat aussi en indiquer votre nom et votre pays d'origine. Next slide, please. So I also just wanted to share some exciting upcoming initiatives. So the Newborn Toolkit has recently opened an essay contest, and this will be open until the 10th of October. The contest focus on how can a neonatal care team with multiple professional backgrounds overcome hierarchies to improve quality of care and enable families at the center. So there's some exciting prizes, £500 and a certificate, publication in the Journal of African Neonatology, several networking opportunities, including being featured on a webinar in November, and a guest spot on the Global Neonatal podcast, which Mbozu also co-hosts. So we encourage submissions. We had submissions last year from parents, researchers, clinicians, so lots of different backgrounds as well. Next slide, please. And without further ado, I will hand over to our lovely host today, Dr. Udoak Okomo. Dr. Okomo is a pediatrician and assistant professor of maternal and newborn health at MRC Gambia at the London School of Hygiene and Tropical Medicine. She is the coordinator for maternal and newborn health research at the MRC unit in the Gambia. And we are very excited to have her here today as our host. So without further ado, I will hand over to Udoak.
Thank you, Lauren. So a warm welcome to everybody joining us today. Good morning, good afternoon, good evening, wherever you are. So we're excited that you're joining us for today's implementation toolkit seminar. And we have a very interesting lineup of speakers who are going to share with us insights and insights on what we can do to tackle the global problems of healthcare-associated infections and neonatal sepsis, especially in LMICs, but generally across the world. And so without further ado, I'm going to introduce our first speaker. She's a very good friend. We've collaborated severally, but never met in person. And so Professor Angela Dromowski, so she's a pediatrician and an infectious disease expert working at the hospital, Stellenbosch University Tyberg Hospital in Cape Town, South Africa. And her research is focused really on epidemiology, diagnosis, treatment, and prevention of neonatal and bacterial infections and antibiotic resistance infections. And she's really passionate about patient safety and data-driven improvements in the quality of hospital care for newborns and sick children. So Angela, over to you.
Thank you, Uduak. Good afternoon, everybody. Please bear with me if you hear a loud noise in the background. Today, I wanted to discuss with you the impact of antibiotic resistance on newborn health in Africa and Asia and other low middle income settings. Next slide, please. And the slide after that, please. So that, as we know, the first 24 hours of life and indeed the first 28 days of life are the most vulnerable period in the life of a child. A baby born in Africa or Asia has up to 10 times higher risk of dying in the newborn period than their high-income country counterparts. And as you may or may not know, in the near future, 80% of all babies born globally will be born in Africa and Asia. And this will only further increase the huge pressure on maternity and newborn birthing units in these continents. Unfortunately, we still have 2 million neonatal deaths per year globally, with 95% of these occurring in low and middle income countries. And perhaps most depressingly, the dark blue bar at the bottom shows zero decline in deaths on the African continent. The top 3 causes of neonatal death remain the same: prematurity, infection, and neonatal encephalopathy, with infections now responsible for more than 3 million sepsis episodes and up to 700,000 deaths. Next slide. In many neonatal units, huge strides have been made in improving early deaths from prematurity and from encephalopathy. But an unintended consequence of improving early survival is that many babies survive just to die later in the 2nd or 3rd week of life from neonatal sepsis, as was seen by our colleague Vicky Nakibuka in Uganda. In another fascinating study conducted in South Africa, in the largest neonatal unit in the country, Baragwanath Hospital, neonatal mortality was investigated using minimally invasive tissue sampling at post-mortem. And they were able to demonstrate in up to 70% of babies who were thought to have died just from prematurity-related complications, an antibiotic-resistant pathogen was the immediate cause of death. Next, please. So why are babies increasingly vulnerable to infection? We know it has a lot to do with suboptimal implementation of infection prevention and control. There are factors related to the neonate themselves, particularly if they are preterm, owing to immature immunity, underdeveloped skin and gut barriers that allow translocation of bacteria across the skin. Healthcare exposures are important. Many babies receive unnecessary antibiotics. To remain alive, we use indwelling devices, and these babies, especially the preterms, have very long hospital stays. In many of our LMIC settings, we have to share equipment. There is poor cleaning of the healthcare environment, and babies are completely dependent on us as caregivers, meaning they are frequently handled and often admitted to units that are overcrowded. Next slide, please. So how do babies acquire pathogens, whether AMR or not? So traditionally, we divide it into vertical transmission, so mother to child, which results in early onset neonatal sepsis, typically described as infection occurring within the first 48 hours of life. And this may be contributed to by factors in the maternal environment: contaminated water, poor sanitation facilities, contact with and consumption of antibiotic contaminated food sources, overuse or unregulated antibiotic use. And there is good data now to show that women in Africa have much higher rates of vaginal and rectal colonization with antibiotic-resistant pathogens. And then, of course, when a woman presents to deliver, they are met with a healthcare facility that often has contaminated delivery surfaces, healthcare worker hands, and equipment. Later onset sepsis, now more typically referred to as healthcare-associated infection, is typically horizontally transmitted to a susceptible infant via the hands of healthcare workers, other caregivers, the hospital environment, and indeed babies that are infected or colonized are a potent reservoir for infections on the unit. Next slide, please. So we have many challenges across the low middle income country settings. In babies, the leading type of infection we encounter is bloodstream infection, typically with gram-negative pathogens that are more antibiotic resistant. I've mentioned the reasons why babies in LMIC become colonized with these bacteria from early in life. And at the same time, we are seeing increasing levels of antibiotic resistance with few new antibiotics agents added to the treatment pipeline. Compounding this issue is there is a lack of large-scale surveillance and in many centers, inaccessible or underutilized blood cultures, which would then inform worldwide recommendations for antibiotic use. And so antibiotics have been recommended for over 6 decades, but at the same time, the pathogens and their resistance profile is changing, which leads to a major problem that we call discordant therapy or bug-drug mismatch. Next slide, please. The guidelines, as we've mentioned, have not kept pace, and these are just two, the WHO and the African CDC guidelines. And if you go to the next slide, I'll show you why these, unfortunately, are not well matched to the pathogens and bugs that have been described in these large multinational studies. So resistance rates of up to 95% have been described amongst antibiotics used for early onset sepsis, and data just from one study, the baby germ study in South Africa, shows that coverage rates of antibiotics for healthcare-associated infection are also declining rapidly. The impact of this discordant therapy or bug-drug mismatch is increasing death from sepsis, as it's well described that babies who receive a discordant empiric antibiotic have a 3-fold higher risk of dying. Next, please. Next, please. And so it's clear that along with improved infection control, we need more treatments for babies with neonatal sepsis. And even in this domain of drug discovery, trials, and access for neonates is not equitable globally. Just in the last 20 years, there have been less than 4 new antibiotics licensed for use in neonates, compared to 40 for adults. Next slide, please. There is some hope, though, with several antibiotic trials, some commencing last year and some that have recently opened, including the NeoCep trial, which is a large personalized randomized control trial that aims to enroll 3,000 newborns to rank 3 new combination antibiotic regimens against other existing empiric treatments for neonatal sepsis. Next slide, please. So it is increasingly apparent that if we want to achieve the Sustainable Development Goals for newborn survival, we absolutely need to tackle the problem of antibiotic resistance, as it is crucial to improving outcomes of babies in LMIC neonatal units. At the same time, the optimal treatment regimens for babies affected by sepsis are unclear, and the pipeline of new agents remains slim. Next slide, please. Clearly, there is no magic silver bullet. There's no single intervention that will transform the landscape for babies affected by sepsis. Things we as the community need to prioritize are strengthening of maternal newborn care, essential care, including infection prevention and control, better development of diagnostics for rapid confirmation of neonatal sepsis and antibiotic resistance, We need to do better at surveillance of infection, especially remaining blood cultures so that we can inform antibiotic treatment guidelines. We should be investing heavily in accelerating antibiotic discovery, neonatal sepsis trials, and access to these new approved agents. And lastly, to promote antimicrobial stewardship so that we can conserve these treatments for the future. And all of this needs to be underpinned by strategic global partnerships, more advocacy, better policies, much more funding, and capacity development for the people at the front line who will care for these babies, the future of the world. Next slide, please. So thank you for joining today. Thank you for your interest in this area. And we absolutely salute the many, many people, many of you who are involved in these partnerships and research studies to improve the care of newborns with sepsis. Thank you, Uduak. Back to you.
Angela, thank you for setting the scene so nicely and for highlighting the challenges that are faced, and also for indicating areas where there's solutions that are kind of almost like low-hanging things that we can start doing now, and things that maybe will be later on along the line. I did forget to mention, please, that if you have any questions, post them in the Q&A session. There's a section there, there's a button at the bottom of your screen, and so you see Q&A. So please post your questions there, and the speakers will do their best to address the questions during the seminar. We might have time at the end for some more questions, okay? So next we're gonna have the amazing Lauren talk to us about the HII, so hospital-acquired infection action pathway. Lauren is a neonatal pediatric nurse, and she is involved in supporting knowledge management and implementation of the newborn toolkit. She's worked in several institutions, and she's going to show us what we need to do next. So over to you, Angela.
Perfect. Thank you, Uduak. Next slide, please. Yes, it's a pleasure to be here today, and I'm discussing a new tool that we've launched. If you've attended some of our previous webinars, we've had discussions about other action pathways. But for those who may not be familiar with it, the goal of the action pathways is to support acting on practical evidence and making it more actionable for those implementers in the front line of a small and sick newborn care. So it helps to simplify complex system change and helps make resources findable across the health system components. So looking at things like infrastructure, medical supplies and devices, infection prevention and control, like we're here today discussing. And these action pathways were co-designed by parents, clinicians, researchers, and other implementers. Next slide. So the action pathways generally take a similar layout, and today we are sharing a neonatal unit outbreak management action pathway. So it sort of covers these key domains. So looking at why is neonatal unit outbreak detection and response important? What do we mean by neonatal unit outbreaks? Who is needed to detect and respond to neonatal unit outbreaks? How do we respond to neonatal unit outbreaks? And then overcoming barriers and evidence. Next slide. So I'll just walk through briefly these key steps to give you an idea of what is involved in the pathway. So the first step is looking at what do we mean by outbreaks, and to discuss healthcare associated infection, what defines an outbreak. So there is a few sort of different definitions in the literature of an outbreak, and we're looking into investigating this further, but we do include a definition, especially in low resource settings. Common bacterial pathogens that might be present within neonatal units, and then common sources of infectious pathogens and outbreaks on neonatal units. So similar to sort of what Angela was discussing previously, with some resources to support this as well. Next slide. The next step, so we're looking at who is on the action team. So there's different levels of stakeholders involved in response to a neonatal unit outbreak, with the parent, the patient, and caregiver sort of at the center. And then kind of branching out, looking at the different levels, including an outbreak response team, healthcare facility stakeholders, and system level stakeholders. And we do recognize that certain settings may have more resources to respond to these, and different team dynamics come into play as well, depending on unit capacity. Next slide. So the next step looks at how we respond to neonatal unit outbreaks. So this sort of provides a method to walk through an outbreak response. So looking at rapidly assessing the outbreak situation, planning and investigating a response, and then implementing response measures, data-driven monitoring and evaluation, also supporting sort of key indicators that you might be able to look at when you are responding to these outbreaks. And then importantly, also looking at how we can prevent future outbreaks post outbreak management and response. And this really tries to incorporate a systems level approach. So considering the role of education of staff, of human resources, equipment available, unit policies for outbreak management, and the unit culture and leadership, and then also how we can incorporate caregivers within this process as well. And throughout each of these steps, we also tried to pull in key resources that were available to support implementation of these evidence into practice. So on the right, there's some examples of transition precaution tools, different line list templates, audit checklists for different neonatal units, depending on resource availability again. And then examples of outbreak investigation reports that can sort of help provide a summary of the situation and how everything unfolded and what was done. Next slide. And lastly, we recognize that when implementing evidence, often there is sort of common barriers or challenges that might arise. And to help sort of anticipate or to plan in advance of this, but also if you're experiencing this, to help overcome it, we listed some examples of common barriers that different implementers brought forward and shared with us as well, or based on the research and the literature. So one of these, for instance, was managing an outbreak with low use of blood cultures to identify causative pathogens. So as Angela mentioned, as Uduak has focused on her research in the past, there is sort of a gap of blood cultures, and Sarah Collins as well from the NEST 360 team has focused on this. So looking at how we can improve a unit culture of doing blood cultures and trying to bridge that diagnostic gap. And that looks at laboratory and clinical staff linkages and solutions that we can target more closely for these key players. Next slide. So I just want to leave you on what we can each of us do this week. So I'm sure we have many clinicians on the call today as well. But learning more about outbreak detection and strategies. So Angela gave a fabulous overview and also linked some resources there. A lot of these resources can also be found on the pathway as well. So I encourage you to check those out and then also share the pathway with colleagues and unit leaders. And please provide feedback if there's things you think are missing or things that could be improved. It's also sort of an ongoing iterative process, and will incorporate that as well. For facility managers, laboratory technicians, and clinicians, really driving home supporting a culture of doing cultures. It's a big part of infection response to outbreaks. So looking at how we can improve communication within the unit and also training with both laboratory technicians and clinicians. Next slide. So yes, if you're interested in sharing tools, resources for the pathways, please feel free to reach out to the Newborn Toolkit, and you can also access the pathway here using the QR code. It's also currently available in English and French, so we're happy to promote any relevant resources in either English or French. Yeah, I think that's all. Thank you.
Thank you, Lauren, so much. I think it's really important that we have an action pathway to follow so that it kind of gives clear guidelines on what to do, and always, all those are always very, very helpful. You did mention something that Angela had discussed before, and something also that like you also said that I've been quite interested in, and that's the diagnostic gap. And we really have that problem in many facilities, especially those facilities that are not in very big cities where they have all the equipment. what do you do when you suspect neonatal sepsis? Of course, we would always want to rush and start antibiotics, but it's important that we diagnose the infection properly so that we're able to treat properly. Our next speaker, Hannah, is going to talk to us about outbreak detection where blood culture use is low. So Hannah is a social behavioral scientist, and she's worked for over 10 years with looking at qualitative research in health. And she's an quality improvement coach dedicated to ensuring that newborns not only receive the interventions, but quality interventions so as to reduce mortality. And so she's the quality improvement manager for the NEST 360 program at the Kenya Aga Khan University, leading efforts to enhance the quality of care for small and sick newborns. So Hannah, over to you. Would like to see what we can do where blood cultures are not usually the norm or where their use is low. Thank you.
Thank you so much, Doc. I'll be taking you through what has been done in 5 countries to close the infection detection gap. Next slide, please. So what is the current burden, or why does neonatal infection detection matter? And as said by the previous speakers, is that the burden on infection is like 23% out of the 2.3 million deaths that occur globally. And looking at the admission rates, 30 million of the estimated small and sick newborns requiring admission are at risk of healthcare-acquired infections and AMR. However, we do have a quality statement from the WHO on what is expected from us. That is, all newborns should be assessed for infection, and when necessary, they should be investigated, given the correct antibiotics, and at the same time, avoiding the overuse of antibiotics. The question is this what is happening at the facility level? Is this what we are doing to the newborn when admitted at the neonatal unit? Looking at a publication in the year 2022, the blood proportion of newborns at the health facility whose blood culture is requested before antibiotics is quite low, as indicated by that graph. Next slide, please. This has also been shown by the NEST 360 data quantitative findings, whereby the country level blood culture gap seems to be quite big despite the lab capacity. In the first graph, you look at the bar for the purple and blue, and you realize the big margin between the antibiotic administration versus the blood culture being done across the 5 countries being implemented by NEST 360. That's Malawi, Kenya, Tanzania, and Nigeria. And even across all the 4 countries, we still see a very big gap when it comes to infection detection. At the facility level, this is still the same, with a significant variation in blood culture use at the facility, with some facilities having very high use of detection, while some even with less than 1% of the blood culture for the neonates. Next slide, please. However, again, we also see the qualitative findings done by the NEST 360 just to explore why do we have these variations when it comes to infection detection at the 4 countries. This was done by a team from the 4 countries, Malawi, Nigeria, Kenya, and Tanzania. We selected facility with one having the highest performance when it comes to neonatal blood cultures, and also one with the lowest blood cultures being done, however, having the highest admissions. And as you can see, the numbers varied across the facility. Our tools were informed by the health system building blocks, and our interviews were done at the ward level to doctors and nurses, and also at the ward level among the technicians and the lab manager. All this was with the aim to explore what are the barriers, what are the enablers when it comes to infection detection at the facility level and also at the country level. Our next steps is that we'll continue analyzing the data, providing feedback to the relevant stakeholders that are required to ensure that this gap is also closed. Most importantly is that the data generated from this study will help us add data for action to the next steps. Next slide, please. This is the nested that we have spoken about, and we can see that we have already started having data for action. The data represents 4 countries across the 70 facilities in a live dashboard. And from the graph that is on my left, you can see the 4 countries. This represents the percentage of facilities doing blood culture. And you can see for sure in some countries, the blood cultures are being done across facilities. However, when you compare blood culture results recorded, which is at the bottom right, you see there's a very big variation. For example, looking at Kenya, where we have a number of facilities doing culture, we don't see any blood culture results being recorded. And even for those that are recording, we can see very low recording of the blood culture results. So the question is, what happens to the blood culture results? Are we using the results to make informed decision? And if yes, where are they filed that they cannot be accessed? Next slide, please. Again, we look at data across the 4 countries, the 70 facilities, comparing blood culture uptake versus antibiotic use. You look at the first part of the graph, which represents antibiotics for babies with clinical sepsis, almost at 100% for most countries. But again, comparing to culture done for babies on antibiotics, not even close to 50%. So how about how do these babies with clinical sepsis get antibiotics without culture? Next slide, please. So this is neonatal blood culture, is a collaborative process between the neonatal ward and the laboratory. Next slide. So what are some of the facilitators that we can strengthen and some of the barriers that we can overcome? At the neonatal units, the key facilitators include the healthcare worker knowledge, availability of guidelines, affordability of the services, support from the donors in terms of cultures, having strong leaders to advocate for neonatal infection, and having the data to make informed decision. For the barriers, is culture bottles not kept in the ward. Some of the cost is out of pocket, not prioritizing cultures as part of routine care, lack of human resources, especially phlebotomists, sample errors, and lab clinician interaction very poor. Next slide. At the ward level, again, we have effective communication as one of the facilitators, availability of data to make informed decision, external research which supports blood culture, capacity building for our lab people, and then of course, availability of microbiology labs and required resources such as the bottles, servicing of the donated devices, and government support to ensure results can be able to access. However, this is being fought by barriers because of lack of resources, especially the bottles and the reagents, lack of staffing that is adequate for the microbiology service, lack of lab space and the infrastructure required. Biomeds are not trained on maintenance of devices because they are donor dependent. Antibiotics administration before blood culture, hence interfering with the results, and infra issues. Next slide, please. So with all that said, what can we do in the various roles that we are playing for the neonates? In terms of information system, we need to encourage documentation and utilization of the blood culture results. In terms of human resource, we need to ensure they are trained and that the parents are aware of the need to have the blood samples delivered to the ward, and also create a routine culture of having cultures done. In terms of leadership, we need to be very accountable in terms of the resources that have been provided and have protocols to guide our healthcare in the collection of blood samples. For medical devices and supplies, we need to ensure the continuous supply of resources and also incorporate our biomedical engineers so that they're able to do planned preventive maintenance for these devices. Financing, which is very critical, is to ensure health insurance can cater for the neonatal blood culture, and of course, ensure that there's an advocate for the budget line for this blood culture at all levels, be it facility, national, and even regional. Infrastructure, there needs to be microbiology services available throughout the time, and ensure they are well constructed to ensure that the consumables and the resources do not get spoiled. Next slide, please. Lastly, as Alison has said, our takeaway, what can we do now? It's ensure our clinicians and nurses in the ward are trained and ensure samples are collected before antibiotics are administered, and promote a culture of data use and analysis of the growths and the growth pathogens that are being identified. For the lab, we need to ensure biomedical engineers are trained and also emphasize the immediate sharing of results to make informed decision. And the two needs to ensure that there's timely collection of blood samples and transportation, and also ensure that there's communication between the lab and the clinician, and also great teamwork. At this point, we can ensure that those who are advocating for quality of our units is to ensure we have quality improvement projects focusing on blood cultures, and not only the coverage, but also the use of the results to make informed decision. Budget is critical to ensure that the resources will always be available when it comes to neonatal blood cultures. And this is less said, and just to say thank you, everyone.
Thank you very much, Hannah, for addressing that issue. I'm sure there are going to be questions because being able to set up blood culture systems in many hospitals is a problem. But I'm sure when we get to the Q&A session, we might have time to look into that. So our last speaker, but definitely not the least, is Dr. Ramesh Agarwal. He's a professor of pediatrics at New Delhi, where he leads the newborn division and the WHO collaborating center. And he's been very active over the last 2 decades in advancing newborn care through clinical research, education, clinical service, and policy. And he also established the Indian Neonatal Sepsis Network. So I'm also very conscious of time. So without much ado, I'd like to invite Dr. Ramesh Agarwal to take us through their experiences in sick newborn care in India. Thank you.
Thank you. Thank you very much for nice introduction, and good afternoon and good evening for me. To all the online participants. Next slide, please. So I'm going to talk about the hospital-acquired infections, antibiotic stewardship, and how we can reduce them. So I'll like to point out these two important studies that we did in India, along with a few other studies in last 15 years. They established that the sepsis in developing countries is quite different from what we see in developed nations. So the first study was conducted in tertiary care hospital, and then the second study was in the level 2 hospitals in the districts. And these two studies highlighted, next slide, please. Next slide. Yeah, they demonstrated high sepsis rate, high AMR, with 50% of the bugs being MDR. And what was very important is that there was high case fatality even when the pathogen was sensitive and the baby was treated with those antibiotics. I think this was very remarkable finding. And the fourth important finding was that there was no effective diagnosis for the sepsis, even the tertiary care centers. Therefore, the antibiotic usage was very high. Next slide. So therefore, the logical question is, next slide, please. The logical question, therefore, is that, go back, please. That can we reduce sepsis rate and can we reduce antibiotic uses? Because AMR is something that would take time, and we can delay further AMR development. And then second is that since the sensitive babies with sensitive suffering from pathogens sensitive to antibiotics are also dying significant numbers, so therefore the emphasis should be on the sepsis prevention, that how can we reduce sepsis. And that's where, next slide, please. We come to what I call the AIMS model, and this is a package of very simple intervention which we have been doing for last 40 years, and have been able to maintain a very low sepsis rate and a very low antibiotic usage rate, and also a low level of AMR. We know that the Indian units a large number of births, so therefore overcrowding is a known factor, and that makes the resource limitation further problematic. So there are 6 important components for this model. One is that you reduce overcrowding, involve mothers in the care and empower them in the caring of their babies, reduce all kinds of IV exposures, including fluids, antibiotics, medication, investigations, any intervention that requires IV access, curtail them down significantly. And fourth important thing is early and dominant enteral feeding, such that if the baby is stable at birth and baby happens to be more than 28 weeks, 28 weeks or more, then the baby does not receive any IV antibiotics unless there is any valid contraindication, and that baby is given total enteral feeding. And strict housekeeping and infection control measures, particularly hand hygiene, and making nurse the champions who lead the continuous quality improvement efforts. So this is the AIMS model. Comes next slide, please. And I'm going to show you the neonatal mortality rate from 1983 to 2023, 40 years. This paper is about to get published. And this is NMR. You can see that we had a significant reduction in of mortality in 1985-86 when we implemented this bundle of packets. And there was from an NMR of approximately 40, it fell down to below 25. And thereafter, there were many other measures, and this was the time when the sepsis prevention the sepsis program started in the unit, and there was further strengthening of asepsis measures that gradually resulted into further decline in the mortality. This was, of course, the COVID time, and then there was increase in mortality. And this reduction in mortality, particularly during this early period, was largely due to reduced sepsis-related mortality. Next slide, please. I think there is some delay in changing slides. Okay, so these are different epochs. Next slide, please. You can see that this is the rate of culture positive sepsis, and then culture positive sepsis from 1.9% reduced to nearly 0.7% in the last epoch. And there was change in the profile of pathogen. Initially, we had gram positive, gram negative bugs being much more, 82% versus 12%. But as we moved on and we had better control of sepsis and sepsis related mortality, the gram positives increased and gram negative decreased quite significantly. Next slide. I'm going to share with you 4 stories, and 3 of them are based on the AIMS model and have been carried out by the fellows that have been trained at AIMS and subsequently went to different parts of the country. And this was myself, who was working as a faculty in charge of one newborn unit at a place which is 200 miles away from Delhi in the state of Rajasthan. I was the faculty member. It was a very busy unit, a large number of babies, hardly any resources, few nurses and few residents. Next slide. And we implemented this package, and what we found that this was the control period, and this was the period when we implemented this package. The adverse outcome rate, which includes death, LAMA, and referral, decreased from 41 to 23%, a reduction of nearly 40%. Next slide. And if you look at the survival rate of the babies between 1 and 1.5, this improved from 21% to nearly 60%. Next slide, please. And this happened through decrease in the unit census from 28 mean to 22. Antibiotic uses were reduced from 72% to 23%, and newer antibiotic uses decreased from 33% to 2.6%. This was 2005. So newer antibiotics were in that context, and length of the stay decreased from 8.6 mean days to mean of 7.1 days. And this was largely, next slide, please. This reduction in mortality was essentially due to reduced sepsis mortality, and there was 70% reduction in sepsis-related mortality, signifying that this simple package of intervention in most resource constrained environment would reduce not only sepsis and sepsis-related mortality, but also will contain the AMR. Next slide, please. I'll go to now the second story. Next slide. The second, which is the another state, which is approximately some 750 kilometers away from Delhi, Madhya Pradesh. Next slide. And we, next slide, please. Yeah, please. So there we worked in one of the district level SNCO. These are the neonatal level 2 neonatal units. Did the fishbone analysis that why antibiotic uses was higher. Next slide. And came up with a simple antibiotic policy algorithm that because the blood culture and the sepsis diagnostics were not available, and implemented this with the support of the facility staff through training, education, and partnership. Next slide. And what we found was that over period of time, the antibiotic usage rate decreased from nearly 50%, 55% to around 30 to 35% through a couple of PDSA cycle. Next slide. And this happened just over a couple of months. And this experience was further replicated in 3 more SNCOs in the state of MP, and antibiotics uses decreased from 50% to 15%, 40 to 27%, and 53 to 28%, while the antibiotic uses remained the same at other places. This happened from July to December. So this package worked quite well there. Next slide. Third story is down south in the state of Karnataka. One of our fellows went there. Next slide, please. And then he, through QI approaches, implemented the package, and with targeting increase in enteral nutrition and decreased IV, and there they were able to reduce antibiotic uses from 85%, signifying that use of antibiotics was a norm, to something like 27% in couple of months, 85% to 27%, and that was sustained even after 6 months of institution of the intervention. Next slide. And you can see that the use of IV fluid was also reduced. This fourth experience comes from the state of Bengal. This is from a different group, of course, and it was not following the AIMS model. They developed their own model of antibiotic stewardship. Next slide, please. And there they found they trained nurses and doctors in antibiotic stewardship, ICP, and the use of an antibiotics form. And the consultant makes sure that justification form was implemented and that other practices are basically reinforced. Next slide. And the results were quite I would say quite significant, that antibiotics consumption decreased from 22% to 58%, and this was approximately over 3 to 4 years, and it was sustaining. The survival rate from 80% increased to approximately 90%, and the mortality rate decreased from 6.7 to 2.1%. This difference that you see is that survival is 90%, but here you see 2% is that in India we combine mortality, referral, and LAMA together because most of these babies actually died, therefore they are combined together. And the referral rate was also decreased quite significantly. Next slide. And duration of stay from 9.1 days reduced to something like 4 days. Next slide. So I want to highlight that this simple package of intervention works quite well. And the key to success are the leadership engagement. You have to have a champion at the facility who drives the change You have to have buy-in by the facility team, and there must be commitment not only from the facility team, but the senior leadership also. And you have to have a basic systematic data-driven approach. This word actually sounds a bit scary, but it's using data, very simple data that you collect on day-to-day basis and use them for driving the change. And of course, there is some amount of hand-holding is needed to begin with. Next slide. I conclude my presentation with these two key messages, that the simple interventions can reduce antibiotic uses, sepsis rate, and sepsis-related mortality, and leadership, champions, and team engagement are critical for this success. Thank you. Thank you very much.
Thank you, Dr. Ramesh. Spot on time. Great with your timing. Thank you so much for showing us that with the right leadership, the right commitment and dedication, that it's possible to reduce mortality from neonatal sepsis and also prevent overuse of antibiotics. I think that's very, very encouraging. So next, we're going to go over to Sally Ellis. So she's the project leader for GARDP, the Children's Antibiotic Program, and she's responsible for the management of clinical activities, particularly focusing on improvements of treatments for neonatal infections. So she's going to lead the Q&A session. So far, I know we've had 2 questions in the Q&A box. One has already been answered. So please, if you do have any questions, we'd really love to engage with you. So kindly type your questions in the chat, the Q&A box, and so we can take them. So Sally, over to you, please. Thank you.
Apologies. Okay, thank you very much for that introduction, and thank you very much to all of the presenters for some extremely interesting presentations. I've already learned a lot, as I'm sure I have many of the people here. So one of the questions that I've got is just around so reducing IV exposures and early enteral feeding. Sometimes it can be ignored as a driver for infection. What are the process measures do you monitor to ensure that family empowerment is done systematically, to engagement in that? And it maybe to Ramesh to start off, but I think that's also relevant for others, because I think it's quite often it's important to engage with the families to make sure that they're involved and aware of many of the issues. So maybe starting with Ramesh, and then we can move to some of the other presenters.
Yeah. So thanks, Ali. And if we talk someone who's in developed nation and engagement of family, that sounds, it is taken for granted, and it's very much part and parcel. But that does not happen in many of the units in LMICs. So therefore, first and foremost thing is that the culture change, wherein the providers see the families as the partner. I think that is the first step. And once you have that, then you put in place a system where the mothers and the other family members are brought into the unit, and they are gradually trained to take care of their babies, follow the asepsis measures, able to feed, do KMC, etc. So that's kind of, for each family there would be a journey, and it would require the engagement by the provider team in a very empathetic way.
Thanks so much. Maybe I don't know, Angela or perhaps Lauren might be able to give a perspective from the African context, or add to anything to that.
Thank you very much for the question. I think it's very relevant, and Jonathan, who answered, and Viola Tembo, an IPC nurse working in Princess Marina Hospital, I think are exploring a really interesting model of family-led infection prevention and control, exactly speaking to what Ramesh has described as empowering families who are at the bedside to be very active champions for their neonate. There have been other studies that have shown how successful mothers can be at influencing hand hygiene compliance rates And I know our colleagues in Zimbabwe are exploring that at the moment to improve their hand hygiene compliance. We've involved mothers previously in a environmental cleaning intervention, which we called NeoClean. It was also a multimodal or bundle type study where one aspect involved mothers being partners in doing sort of high level dusting and wipe downs of the immediate newborn environment, either the baby's crib or the incubator or the surfaces of the bedside cabinets. And again, also exploring roles of moms in encouraging hand hygiene. The other simple measure is actually to inform mothers and families with information. And so people have explored that differently, but there are some examples of information sheets just explaining the basic concepts of how infection is transmitted to a newborn baby that is hospitalized. And that information alone can empower mums and families to do better in terms of IPC. But I think Ramesh's first point is the most critical, is that we need a culture change of neonatal units and neonatal unit care providers to see parents and families as partners. Over.
Thanks, Angela. So maybe following on a little bit from that and linking to some of the other, I mean, lots of the discussion has been around sort of blood cultures and the feasibility of doing blood cultures and very often where it's not done. And maybe just to think about how is it possible to improve the blood culture rates through involvement and to be linking to the patients and to the parents of the patient for that. And maybe Hannah, you might be able to respond. Anna?
Yeah, thanks for the question. I think one critical way to ensure that the results are being utilized is first to improve the communication between the lab and the newborn units. I think it doesn't also have to be very formal in terms of communication of results, but any form of mode of communication that can be used. We have seen even facility, whenever there's a kind of growth identified, they can really quick chat with the newborn unit and be able to tell them, hey, this has been identified for quick action, and maybe ensure that there's just somebody dedicated to ensure that results are being collected and followed up in the lab. And then the other thing is to make sure that there's routine culture during handover process, such that as you hand over the patient, the question is, was culture done? At what point was it done? Are the results available? If they are not, why are they not available? And being able to follow up rather than waiting during discharges when you realize this baby had culture done, but we didn't have results even at the point of discharge. So critical effective communication between the lab and also the newborn unit, and ensuring that culture is part of routine care, such that it's taken as a very important aspect when it comes to newborn care. Thank you.
Thank you. So we're very close to the end of time. Maybe just one last question, and just very quick for all four of you. So if somebody's starting out on this, how do we get started? What is the one thing that they should do to start off with first? Maybe Angela?
Thanks, Sally. So I think quality improvement, small cycles of quality improvement, using your data to convince your team that this is a real problem, and so that they can see the progress and be part of the improvement cycle. Thanks.
Lauren?
I think encouraging family involvement at the bedside and making sure you can incorporate them within the IPC prevention practice, I think is also a really key aspect.
Thank you. Hannah?
I think I just want to emphasize what Prof. Angela said, that for sure, quality improvements start more small, use data even at leadership levels to show them the impact of this infection at the patient level, even to the facility. What do they save when they are doing this culture? And then how do we also promote the safety of these patients when we do this culture? So I think data is very critical. Start small and gradually scale up to the other ways. Thank you.
Thanks. And last but not least, Ramesh.
Yeah, thanks, Sally. I talked about the families. The other important stakeholders are actually the nurses. And, empowering the nurses to take the leadership and be the champion is a game changer. So if we can, mothers and the nurses, if they can be empowered to take charge, the things would change, whether that's sepsis or, the management of RDS, use of CPAP, or even the use of antenatal steroids in the birthing rooms.
Thanks, Ramesh, and
Thank you.
I'll hand back to Udak.
Okay, so thank you very much. Top of the hour, we don't have very much time left, but just a massive thank you to everybody, all our speakers today. Thank you for such enlightening talks. We will make sure that the webinar will be available soon and it'll be shared on our social media platforms. And so please, you can scan the QR codes to use and contribute to the Newborn Toolkit. And just to say that, to reiterate everything that's been said today, that little changes can lead to large results, and that don't think that you can't make a difference in your unit. Start within, start with data that you have within, work with your teams, let everybody feel that they're a part of the solution and not contributing to the problem, and then use the data that you have within your center to drive change from the leadership to the administration. And hopefully we're going to see the numbers decline. So thank you very much and look forward to seeing you on our future sessions. Goodbye.